So today, as I said, is one of my favorite topics. And in terms of our objectives for today, I really want to talk about basic and translational literature that really focuses on walking recovery after a neurologic injury. I also want to discuss recent technological advancements that have allowed us to promote more walking recovery after neurologic injury. And then finally, it's really important that we review the key perspectives of all stakeholders that could potentially benefit from these types of technologies. So although spinal cord injury has a much lower incidence rate in comparison to other health conditions affecting the United States, it still has a profound impact on our society, as it often results in immediate and catastrophic consequences that include loss of upright mobility and loss of independence. Out of all spinal cord injuries, less than 1% of individuals achieve full neurologic recovery. And those who don't, as we know, are often left to rely on a wheelchair as their primary means of mobility. Historically, we didn't even offer walking recovery interventions for people who had motor incomplete injuries because we didn't know how to do it. And oftentimes we didn't have the technology available that allowed us to do that in a very safe way. But fortunately, over the last 5 to 10 years, there's been an explosion of rehab technology on the market that now allows for us to do so much more with our patients. But along with that, again, there's always the pro and con side of everything. There's some people who really believe in technology to promote recovery after injury, and there's some individuals who don't believe in technology. So I hope what we can do today is just take a look at the key of the perspective of all the key stakeholders in this discussion. So I want to look at the p-value, always important to understand what the research says. The second is the practitioner, so important to understand what physical therapists and other clinicians think about technology and how we use technology. Probably the most important perspective, absolutely the most important perspective, is the patient perspective. What do patients feel like they benefit from? And then finally, whether we choose to recognize it or not, the payer perspective is also important. What are we getting reimbursed for, and what are the financial implications associated with implementing these technologies? So I'll start with the best evidence that we have available. And I'm going to have some help in the back, probably clicking, so that, there we go. So there's mounting evidence to support that walking recovery can be improved in individuals who have motor incomplete spinal cord injury. A quick review of the literature would tell us that this is beneficial in both chronic as well as acute conditions. The largest of the studies to date is a prospective cohort study of 196 individuals with age impairment scale C and D injuries who demonstrated significant improvements in walking function and balance from pre to post intervention. Now the intervention phase was quite variable because it was actually in the clinical care setting, so that obviously then is dictated by insurance. But I think the most important thing is that these results were published and they were significantly better than historically reported outcomes. So the fact that we were provided intensive locomotor training really helped these individuals to improve their walking function. So here's just an example of one of the randomized controlled trials that have been completed in spinal cord injury. So this was done by Adele Field-Fote when she was down at the Miami Project. And she looked at 4 different groups. It was a randomized controlled trial. The first group received intensive locomotor training in a body weight supported environment with manual assistance. The second group received robotic locomotor training, so a big robot called the Locomat in a specific case. The third group received overground walking with functional electrical stimulation, augmenting that walking practice. And then the fourth group received locomotor training on the treadmill, also augmented with electrical stimulation. But the stimulation was at very, very high intensity, so it almost exhibited more of a withdrawal reflex type of intensity. And what she found in looking at these 4 groups was that there was statistically no significant difference between walking recovery rates among the 4 groups. But again, all walking recovery in all the groups was significantly better than historically reported outcomes. So that, as a clinician, tells me that it may not be so important what specific intervention choice that I choose, but that our conventional system in healthcare doesn't allow us to often help people receive the amount of intensity that's required to achieve our optimal outcome. So then if we look at our highest level of evidence, we just talked about systematic reviews and a Cochrane review. So same thing, there's been a lot of evidence out there, and more evidence to date that would tell us that we are showing benefit from some of these walking intervention approaches, but to date there's not a clear winner. So we're helping people get better, but we don't know the specific way that necessarily makes a difference. The one caveat is that most of the randomized controlled trials to date would say that individuals receiving treatment augmented with functional electrical stimulation seem to do a little bit better, especially in the subacute and chronic conditions. And then if we talk about stroke, which is not my specialty, but there was another study called the LEAPS trial that came out, and they also looked at the difference between individuals who received intensive locomotor training and then those who received home-based physical therapy. Again, what they found, there was no statistically significant difference between the two groups, but then they also compared them to a third intervention group, which was usual care. Those individuals receiving just outpatient physical therapy 1 to 2 times a week. And even though there was no difference between the first two groups, who were getting intensive therapy 5 days a week, one in the home and one on a treadmill, they did see a significant difference and significant improvement from both groups over the usual care group. So again, a different diagnostic population, but also giving us the same information that the intensity and dosage may be really important in helping people improve their walking recovery. So the next area I want to look at is clinical expertise. And so as a practitioner, I have all these questions in my mind when I have a patient that comes to see me. But first and foremost is, how do I promote recovery? How do I help this person recover? And I think we all, obviously, that's one of our first questions in meeting a patient. The second is, how do I take what recent knowledge is of neuroplasticity and priming, and how do I use those concepts to help someone potentially recover? And then third, how do I take my knowledge of motor learning principles and also implement those into the mix? And so we're going to talk about those with a couple of case studies. So this is a former patient of mine. His name is Sharon. He was admitted into inpatient rehabilitation at Craig. He was 31 years old, a married father of 2. He had a C4 age impairment scale C spinal cord injury upon admission. And so remember, AGC is they're probably wiggling a few toes, but very few muscle grade strengths, if any, that are greater than 3 out of 5 below their level of injury. His biggest goals were to play with his kids, to walk, and to get back to work. And so he received a paradigm of locomotor training as well as functional electrical stimulation to both the upper extremities and the lower extremities. So I want to just show you this video on the left with Sharon. This was actually his discharge from inpatient rehabilitation. So I feel like I work at a great facility, and I'm so proud of the work we do, but this is how Sharon was going to discharge home. So you can see he's completely dependent. That's his therapist on the mat. He's dependent for supine to sit. His wife is using a Hoyer lift to get him in and out of the bed and chair. He really has no functional strength on his own at this point. But remember, he did have some movement because he was age impairment scale C. If we look at the video on the right, this was his initial evaluation in our outpatient rehabilitation program. And what you can see is it takes 3 of us to get him into an upright standing position, and we're not even very successful at it. He's got a lot of spasticity, a lot of tone. You see that right arm move into extension. And we're essentially taking 3 of us and holding him up into a standing position, but he's really not initiating any of this on his own. So we're going to kind of follow him throughout his rehabilitation. So I guess my question for you is, as a primary therapist, what are my challenges with somebody like Sharon? Anybody have any thoughts? What about my size? I'm not very big, right? So if I'm going to get Sharon up on his feet, which the literature would tell me is my job to help him recover, how am I going to do that in a safe way? I'm either going to have 3 other people with me all the time, or I'm going to have to use some sort of technology to make that happen, right? So then I want to show you a second case study. This gentleman's name is Pete. He's 54 years old. He has a C5 age impairment scale C spinal cord injury. Same kind of thing you can see here. You can't really see me because I'm underneath him at this point. But his goals are to return home, to walk, to have limited caregiver assistance, And he also received intervention paradigm of locomotor training and functional electrical stimulation. And I think Pete is a really interesting case because Sharon was going home to a wife and children, which has its own challenges, I know, but at least he had some help at home. Pete was from rural Montana. He needed to be independent with going home, or he was going to have to go to a skilled nursing facility, and that's the last thing that Pete wanted, and obviously it's the last thing that we wanted. So some different challenges. Pete physically presented very differently. Although he was also an Asian impairment scale injury, he didn't have spasticity. He was very low tone, whereas Sharon was very high tone. So challenges both ways, but again, I would ask you as a primary therapist, what would be my challenges in working with somebody like Pete? Same kind of thing we talked about with Sharon, right? He's big, he's weak, and my job is to get him on his feet and keep both of us safe. So when we think about neuroplasticity, if you Google neuroplasticity, you'll get over 43,000 hits. In my opinion, it's one of the most commonly and overused terms in rehabilitation that's been in the literature in the last 5 to 10 years. So I'll tell you as a primary therapist, what I think about when I think of this term. And that's that my job is to provide interventions that help facilitate the rearrangement of the anatomical and functional connections of the neurons within an injured nervous system so that we can either hopefully reorganize existing pathways that have been damaged by the nervous system or by the injury, or regenerate new pathways that can continue to carry that important motor and sensory information that can allow us to promote that improved recovery. Now, when you think about, if you go through the literature, which I won't have time today, but happy to talk to you afterwards, there's been a lot of proposed mechanisms for how this plasticity actually occurs, but the one common element among all of them is that intensive therapy is critical to success. So we may not know exactly what that therapy needs to look like yet, but we know that it needs to be intense, it needs to be task-specific, and we need to find a way to do it even in the acute stages of recovery when somebody's very dependent and not able to help us. So a primed nervous system is thought to be more responsive to training. And priming is a type of implicit motor learning in which a stimulus prompts a change in behavior. And there's two main types of priming in the literature when we look at it. One is homeostatic priming and one is gating. And essentially gating is providing enhanced neural activity just during skill-based training so that we can produce long-term potentiation or long-term depression-like principles. And then a homeostatic priming is actually providing that enhanced neural activity just prior to skill-based training so that we're creating a really rich environment, including a lot of growth factors. We know how important BDNF and other growth factors are for that reorganization and regeneration of pathways. And so homeostatic plasticity would have us really provide that enhanced neural activity just prior to doing some sort of skill-based training, like walking recovery or upper extremity reaching, anything like that. So it's where a lot of our literature is really focused to date. As I talked about BDNF, the exciting, how many of you are runners? Bikers, some sort of aerobic junkie, right? There's many of us. And I think that's one of the things that gets me out of bed in the morning is a reminder that when I get moving, I'm increasing my BDNF levels both peripherally and centrally, which creates a really rich environment for my nervous system. So that when we do have accidents, which we all do, I actually recently had a bike accident myself, hopefully we have a really protective environment for some of our nervous system so that we don't have some of the longer-term neurologic complications that you see. But a lot of good evidence to support how important BDNF is. So when we look at this in the rehabilitation environment, it looks very different, obviously, than you and I out running on the road or using a bike. So if you see this first video on the left, a very low-cost option for doing this. This is a new step. Most PT clinics have something like this in the facility. In this environment, we actually have electrical stimulation on the quad of this gentleman. So the therapist is just triggering it with a simple $30 hand switch every time he's pushing into extension. She's augmenting that activity, as I said, neurally with that electrical stimulation. I work again at an amazing facility where we have a ton of technology. And the second video is a gentleman who's actually using an RT600, which is a bodyweight support system that incorporates 12 channels of electrical stimulation. So on this gentleman, we actually have electrical stimulation on his abs, his trunk extensors, glutes, quads, hams, plantar flexors, and dorsiflexors. So a lot of electrical stimulation. How many of you all have put electrical stimulation on yourselves? Can you imagine 12 channels that are getting a motor response at each one? It is literally an overstimulating environment. But again, we're in this type of situation, we're looking at that homeostatic plasticity, augmenting the neural activity just prior to working on overground walking training. Here's just a couple more examples. The video on the left is called the Origo. Again, we're augmenting electrical stimulation on the lower legs as we're using that stepping mechanism. Video on the right, we do a lot of manual locomotor training where we use foot drop systems, other types of functional electrical stimulation to augment that practice while we're working on that skill-based training. Here's another one, then we take somebody overground. So we took this gentleman on the video on the left, right off the treadmill to the overground condition. So working on task-specific practice with that augmented electrical stimulation. And then the video on the right, we don't forget about the upper extremities, even though I do get accused of that from time to time. But this gentleman is actually in our gift shop, and we're stimulating the appropriate muscle groups with both his flexors and extensors of the upper extremity to work on grasp and reach. So Jeff Klein produced a really great paper in 2008 that looked at these 10 motor learning principles that we should be incorporating in neurologic rehabilitation. And as I said, I think we've all known these neurologic principles for a long time, but sometimes it's difficult to implement them without the right technology. So I'm going to go through and talk about how we can use some technologies to be able to implement them. So this is one of my favorite patients. So this video on the left, I hadn't been at Craig very long, and they called me and said, one of our therapists called in sick today, can you come and cover this patient for us? So as I helped him transfer over to the mat, I saw this beautiful synergistic activity in his lower extremities. None of it was under his volitional control, but it was really pretty. And so I said to him, are you able to move your legs? And he says, no, I have a spinal cord injury, I can't move my legs. I said, okay, well, I want to just try something, because I'd seen this with a few patients before. And so I'll have you play the video on the left again. Sorry, on the left, yep, sorry. So if you see on the left, he's like, are you stupid? I just told you I have a spinal cord injury and I can't move my legs. We've since become friends, but he was really frustrated with me at that moment. So basically all I did is I helped him transfer into over his chair, and I said, can you try to move your legs now? And that's when he got frustrated with me. And then I said, now I want you to scoot your hips to the edge of the chair, and I want you to try to do the same thing. And so we'll play the video on the right. And what you can see, he went from not being able to move his legs at all to creating this really beautiful flexion and extension pattern that looks very much like walking, right? So he's able to switch between synergies. He's not able to isolate anything, which is why he hits his quad. Somehow he thinks that's going to help him dorsiflex his foot. I'm not really sure the logic there. But nonetheless, the exciting part for me was to understand that that nervous system had so much more capability than he knew. And he was 3 years post a spinal cord injury. And it only took a little bit of education to help him understand how to use those synergies. So although it doesn't mean that he's going to get up and walk out of that chair right now, it still, I think, is really exciting for us to see how much potential there really can be in an injured nervous system. So then what's my job? My job is when I see that movement, get him on his feet and try to figure out what he can do with it and teach him how to do something functional with it. So in terms of this left video, you'll see this was actually the first time I got him up on his feet. Started giving him some manual facilitation to try to get that spasticity or that synergistic activity going to help me in a standing position. The left leg, he was able to initiate some extension. The right leg, he's not really able to do anything. But nonetheless, it was exciting for me to see that he at least had something when I transitioned him to an upright position. And then we'll take a look at the video on the right. So with a lot of practice and a lot of intensity, what you can see is that he's able to create a walking pattern on his own at this point. Is it perfect? Is it beautiful? Is it functional all the time? Absolutely not. But sitting in a chair for 3 years and not even knowing you had the ability to move your legs, to now being able to walk in this kind of capacity, I think was really exciting for him. And this is a piece of technology that we have that allows us to do this. So it's an overhead bodyweight support system. I'm actually not taking any bodyweight support off of him. All I do is have the harness on him so that if he were to fall, or if he were to trip, it's going to keep him from falling. But there's a lot of research coming out now to support that the intensity and amount of walking practice is critical to success. So here's another gentleman. I use a lot of functional electrical stimulation, and this was a young kid with a T4 Asia Pyramid Scale C spinal cord injury when I first started working with him. The exciting thing about him was he had almost functional movement in his right lower extremity, but he had no functional movement in the left. So in terms of grading the left, he was 0 out of 5 throughout the left lower extremity. And then, again, the right was about 3 out of 5 in most major muscle groups. So when I asked him to move the left, it did nothing, right? But if I put electrical stimulation on his dorsum, I was able to get a flexor withdrawal so that I got flexion at both the hip, the knee, and the ankle. So without electrical stimulation, he can move nothing. And even with a normal foot drop system, it wasn't strong enough to break through his extensor tone. So that's why I went back to the research and found a 1970 article that showed that if you put e-stim on the paws of the dorsum of cats, they actually got a very large stepping response. So I thought we would try it, and it actually worked. So then if we take it overground in that video on the right, what you'll see is I'm digging my fingers into his hamstring tendons, trying to elicit a step, but we can't really do anything. And it's only when I trigger the electrical stimulation do I get that really nice stepping response. And so then my job again is to teach the nervous system that stepping response again so that it no longer requires the electrical stimulation, hopefully to prompt it. So this video on the left, I have him turn off his FES system before we get going. And what you can see is that after about 6 weeks of intensive training, he can now produce a step with that left lower extremity without requiring the stimulation. So another exciting thing is that the nervous system is learning. It's learning what we teach it. And in this capacity, it learned that it could create that flexion response in the walking pattern. And then this video, he actually on the right, he sent me once he got home. He's no longer using the electrical stimulation. You can see this is just in therapy one day. But he was really proud of what his stepping looked like that day, so he sent me the video. He still has the functional electrical stimulation system, but generally doesn't use it unless his tone is really high that particular day. So repetition and intensity are part of the motor learning principles that we talked about that are so important. So this video on the left is a robotic locomotor training system that we're fortunate to have. So we'll play that video. And so essentially this allows me, even if somebody just has a toe wiggling, or if they don't have anything wiggling, I can get them upright, weight bearing, and moving in a walking type pattern that's appropriate for their body. It also has augmented feedback, so there's 4 sensors at both hips and knees. So any initiation or any force the gentleman puts into the stepping or walking pattern is graphically represented on the screen, so we use it for feedback. And then he also can control an avatar. So again, he starts to learn how his initiation then can control his environment. If you look at the video on the right, this is actually Sharon. And Sharon ran a track in college, so he was really interesting because he actually did much better the faster we stepped him. And I think that his body already knew how to run, and that's what it was its go-to pattern. I don't have any evidence for that. All I know is that's really intensive work when you're stepping somebody, and for us it was easier to step him at very high speeds than it was to step him at lower speeds. So, again, just more evidence to support that we need intensive stepping training to promote walking recovery, but we also need to allow individuals to make errors. If we don't allow them to make errors, the nervous system shuts down, becomes very inactive, and it's not learning anymore. So we always need to be kind of right on that verge of the optimal challenge that they can actually undertake. So another new technology that we have, this video on the left, we have an underwater treadmill system. So many of our patients in Colorado, one of their biggest goals is to get back to running again. But again, as a primary therapist, that can be really difficult to keep somebody safe when they're practicing this. But the underwater treadmill system, the entire floor is a treadmill, and it raises and lowers with it. So I'm in the water with somebody, I have a little remote, and I can put it at any height I need to promote the appropriate buoyancy. They also have a camera system, so on the video on the right, you'll see as the gentleman is running, he and I both can see what's going on with his pattern. We can make sure he's safe, and we can also try to improve that pattern. So this type of technology is really beneficial for both, in my situation, both our spinal cord injuries as well as our brain injury population. Another new advancement that's allowed us to get people back to running again as well is the Ultra G, which is another treadmill system with body weight support, but it's actually supplied by air. So in this video, you'll see this gentleman actually had a brain injury. He wanted to get back to triathlons, and we're taking a little bit of weight off of him with the air bladder, but for the most part, he's getting a really good cardiovascular workout and learning how to run again. He also has the camera system so that he can monitor his pattern and then change it as well. So transference and salience are 2 other important motor learning principles. And transference essentially is that plasticity within one set of neural circuits is used to promote plasticity in alternate circuits. And so if you see this video on the left, this gentleman is working on doing a sliding board transfer. So you'll remember that was Pete. He was one of our case studies that we're kind of following. And you can see at this point that to do a transfer, the goal here is to only require one person physical assist. And you can see it's still really difficult for him. So he is, again, leading inpatient rehabilitation. He actually had a nurse that came and stayed with him in the apartment because he wasn't independent with his transfers and didn't have any family members. So he and the nurse were using a Hoyer lift to do all of his transfers. However, if you look at the video on right, after only working on walking training, not working on transfers, you'll see that although it's not perfect, his ability to do a stand pivot transfer is now pretty successful. And so the goal is that we challenge the body as much as it will allow us to, and then some of the easier level tasks actually become more successful. So Pete was able to do a stand pivot transfer without any assistance when he left. All right, so we're going to look at the patient perspective. I'm going to go back and just make sure, yep. We're going to look at the patient perspective, which I said is the most important. And so we need to look at patient values and preferences. So when we have liaisons at Craig, and they go out into the field as soon as somebody's been injured, and they go and talk to the family members about why we think it's really important for them to come to Craig for rehabilitation. And so when I asked the liaisons to keep a 6-month track of how many patients and families ask about the technology that we have available, they said that 100% of prospective patients and families with spinal cord injury ask what technology opportunities their individual will have if they come to Craig. 100%. People are on the internet, they're very well educated, they want to know what opportunities there are. And then 85% of patients and families with brain injury also ask about technology updates. So obviously technology is of value and really important to patients and families who are looking for rehabilitation. Here's just a couple little studies that looked at patient values. And in the top study, it was a randomized controlled trial using a functional electrical stimulation foot drop system for individuals who had a stroke in comparison to using an AFO. So both groups were getting physical therapy, but one group was getting electrical stimulation, one was getting an AFO. And when they completed this study, they found that there wasn't any, same kind of story, right? There wasn't any statistically significant differences between walking speed, walking endurance, or walking function in either group. But what they did find is the group who received functional electrical stimulation was more likely and more willing to use that device, and they perceived that their outcomes were better. So interesting that patients value technology as well. When we look at access to technology, I think this was an SCI Rehab data study that came out a few years ago, and I think this is really important to understand. So if you look at the Asia Impairment Scale C category, which remember Sharon and Pete would both fall into that category. If you have that type of injury and you go to a rehabilitation facility who has a robotic technology system for walking, you are 2 times more likely to get some sort of walking training than if you go to a facility that doesn't have robotic technology. So my point here is that whether robotic technology is better or worse, I don't think is even an issue. But if we're able to provide intensive walking training in some capacity because we have a robotic system, that would tell me that from a motor learning perspective, we're likely to have better outcomes. And so when we talk about return on investment, so this was Pete when he got ready to go home to Montana. He had completed 80 outpatient physical therapy sessions, which included the manual locomotor training system, requiring 4 therapists, which is very expensive for me to run, obviously. And he also completed 80 outpatient OT sessions. But what you can see is that Pete was able to return home to Montana independently to his own home. He did not have to go to a skilled nursing facility, and he only has caregivers that come in every evening just to help with bowel program, help him with the shower, and then do some light household cleaning activities. But the fact that he was able to go home independently was a huge, huge factor for Pete. So if we look at Sharon, in terms of return on investment, this is also, if you look at the video on the left, this is about halfway through his rehabilitation program. So he actually completed 120 outpatient sessions of PT and 120 outpatient sessions of OT, and 60 outpatient OT sessions. About halfway through, he was walking with forearm crutches and somebody just kind of there in case he needed some assistance. So I was really excited just to see that he had made that much progress, given the fact that it took 3 of us to get him into a standing position early on. But if you look at the very end of his program, that video on the right, what you'll see is that it's not a beautiful pattern, but he's walking without assistive devices, without bracing. He's totally on his own, which was really exciting. Quite honestly, I tend to be an optimist, but I wasn't even sure it was going to turn out this way. So we were really excited about that. And then the most important thing, he said he wanted to get back to playing with his kids. So if you look at this video, what you'll see is it's not exactly the way he did it prior to his injury, but nonetheless, he's got both children out there running around playing, and was really able to get back to that father role. He's back to work. You know, he's done a really, really nice job. Now, is this every case that we have? Absolutely not. I wish it were. But nonetheless, it really hopefully is an illustration of how some of these advanced technologies can help us really improve the care that we're providing. So now the Debbie Downer, the financial perspective, right, that we all have to consider. But there's also kind of a light at the end of the tunnel. So here was a study that was published a few years ago, and they actually looked at lifetime care costs associated with people who have spinal cord injury. And they did a case study of 2 individuals for this. And it was a 61-year-old female, so I think very much like Pete in a way. She received 198 outpatient locomotor training sessions, and they projected her lifetime care costs just prior to outpatient therapy and then after outpatient therapy. And what they demonstrated was a 98% reduction in her lifetime care costs associated with those 2 time points. So she would have required a van, she would have required a power chair, all of those really expensive things prior to the outpatient program that she didn't require after doing that. The second case study was a 7.5-year-old little boy who also had a spinal cord injury. He received 68 outpatient locomotor training sessions, and they demonstrated an 82% reduction in lifetime care costs associated with that intervention phase. So although it's really expensive technology and really expensive to implement, you also can see cost savings that will hopefully last throughout a lifetime, that will even be more beneficial than that upfront cost. Exoskeletons. So these have become more and more common now, and there's a lot more discussion around them. And so there's 3 main exoskeletons on the market now. We fortunately have access to all 3 of them at Craig. So this first exoskeleton on the left is called the Indigo. And this gentleman was actually a patient of mine when I was at Shepherd Center in Atlanta many years ago. He has a T8 motor complete injury and has been injured for over 15 years. And so I was at a conference in San Diego, and he was like, "Candy, you gotta go outside with me, you gotta see what I can do." And so he had this, it's modular, so he had it in pieces in a backpack on the back of his chair. We sat out on the boardwalk, he popped it on himself, not making any of this up, and then he was able to get himself into a standing position without assistance, and he was able to walk down the boardwalk in San Diego. Super exciting for me, because although the technologies have come a long way, I've been a skeptic about could we really get these into the community. And I think we still have a ways to go, but they're so much further along than they were even 5 years ago. I think it's exciting. The second video on the top right, this gentleman is using a rewalk system, and he actually just recently purchased this for home. Now, do I agree with that purchase? Not really my business. But nonetheless, I don't know that if I was going to purchase one for home, I would do that yet. I'm not sure they're quite where they need to be in order to do that. They're about $75,000, and he paid out of pocket for that. And then he still requires a trainer or a caregiver to be with him while he's walking. But again, it's really hard for us, I think, to make judgments. He's been injured over 10 years, has not been able to stand or walk in 10 years. So for him, this is reasonable, and this is a good use of his money. And then if you look at the video on the bottom, this gentleman has been injured. He has a T4 motor complete injury, and he's been injured over 20 years. And what the exciting thing for me about this is the Exo by Exo Bionics. And even though he has no motor or sensory information below T4, he's learned to use the system without anybody holding on to him. So very exciting there. Now, important to remember for questions later that there's 2 of these devices that are approved by the FDA for home purchase, and those would be the top 2 devices, the Indigo and the Rewalk. The exoskeleton is not approved for home use, it's only for institutional use at this point. So, in terms of what we learned, We're going to talk, I think, a little bit differently in the questions, and I had some technology issues, so I'm not sure how these questions are actually going to come up. But I think
You're good.
if I just click here. Oh, perfect. Okay, true or false, literature supports various forms of locomotor training to promote walking recovery after spinal cord injury. And I
think they do it.
That's great. Yes, thank you. Okay, we better gotten this one. Oh, 100%. That means I did a better job educating in the previous. Oh, I'm sorry. I didn't realize that. Oops, sorry about that. That was my outside voice. Probably should have said that inside, right? So true or false, priming may create an optimal environment for motor learning. Oh, we're 100% again. Great job. All right, we'll go to question number 3. So, a little more difficult. Still make me look good here. Motor learning principles are one of those 3. I said there were 10, and so you just have to pick the ones that are in there. Ooh. Okay, I didn't do such a great job. So B is the correct answer. Although that was a tough question because there's the duration is the one in the C that wouldn't be. Duration and intensity actually are not motor learning, but they're important. So good job picking that up. And then I can't remember if, oh yep, we have one more question, so let's redeem ourselves. Specific intervention choice is more important than dosage and intensity.